Fatema Ghasia. She is Director of Visual Neuroscience Laboratory of Cleveland Clinic, and she's a pediatrics ophthalmologist and strabismus surgeon, and her research focuses on central causes of strabismus. Fatema?
Hello, everyone. I would like to thank the organizers for inviting me to present. I wanted to briefly introduce myself. I'm Fatema Ghasia. I'm a pediatric ophthalmologist and strabismus surgeon at Cleveland Clinic, and I'm the director of Oculomotility Lab at Cole Eye Institute. And today I'm going to talk about eye movement abnormalities in cerebellar diseases. So as we all know, cerebellum plays a very important role in eye movement control, and I wanted to briefly review the role of different cerebellar areas in control of eye movements. So flocculus and the paraflocculus, they play an important role in stabilizing the image on the retina. And if you have lesions of these areas, it can result in slow phase nystagmus because of the inability to hold our eye still on an object of interest. It can also result in impaired smooth pursuit. The vermis and the fastigial nucleus, they play a very important role of generating accurate saccades. And so lesions of these areas are known to produce saccadic dysmetria. And we'll delve into these abnormalities a little bit more in detail soon. The nodulus and the uvula, they play an important role in the vestibular velocity storage mechanism, and lesions of these areas result in prolonged rotational nystagmus and gravity-dependent spontaneous nystagmus. And then the deep cerebellar nuclei, namely the fastigial, the interpositus, and the dentate nucleus, they've been shown to play an important role on binocular alignment and convergence. And my talk will primarily focus on the role of cerebellum in control of conjugate and disconjugate eye movements, in particular focus on binocular alignment. So the neural circuits that drive the binocular coordination, both the conjugate and the disconjugate component, they're well established. The basic pathways for conjugate saccadic eye movements are well established. The saccadic commands, they originate from the cortical motor areas, and then they go through the basal ganglia to the brainstem premotor neurons that are then transmitted to the oculomotor nucleus and the extraocular muscles. For the vergence pathway, the cortical centers that drive the vergence, they project to the NRTP and then to the cerebellum, and the cerebellar nuclei then in turn go to the supraoculomotor area in the brainstem, and then the oculomotor nucleus and the extraocular muscles. Now, I wanted to first just give a little overview about the role of cerebellum in saccade generation. So, dysmetria of saccades is a particularly prominent sign of cerebellar dysfunction. Saccades, they are rapid eye movements that redirect the fovea from one object to the other. They are fast eye movements. Latency is usually less than 200 milliseconds or 250 milliseconds. They are very high speed, can reach up to 600 degrees per second. They are brief, 30 to 100 milliseconds, and they are accurate, and they stop abruptly with very little subsequent ocular drift. So here's an example of a saccade from a control subject. X-axis is time, y-axis is eye position. The red and the blue are the horizontal eye positions of the right and the left eye, and this down here, the magenta and cyan, are the vertical eye positions, and the green signal here is the vergence signal, which is the difference between the right and the left eye. Notice, and then the black here is the target. Notice that the saccade is pretty accurate. The eye is landed on the target. There is a small corrective saccade, which is commonly seen in saccades of 10 degrees or greater in amplitude. And then there is no subsequent drift of the eye. So once the eye lands on an object, the gaze is held steady. And so the way the saccades are generated is there is the velocity command that is the pulse that produces the high frequency phasic discharge that moves the eye rapidly from one position to the other. And then the step is the position command that provides the steady discharge of the saccades that hold the eye in its new position. Now, in cases of cerebellar diseases, you can have something called pulse amplitude dysmetria, where there is a saccade overshoot or an undershoot. So again, here's a time series from an example of a saccade in a patient with spinocerebellar ataxia. And again, x-axis is time, y-axis is eye position. And the blue and the red are the horizontal eye positions, and the black is the target. Notice that the eye overshot, and then followed by there are also saccadic intrusions that follow the saccade. So this has been attributed to lesions of the dorsal cerebellar vermis and posterior vestigial nucleus. Here's an example of a pulse step dysmetria, where there's a problem with the pulse where you have an overshoot in this particular example, and that overshoot is then followed by a prolonged post-saccadic drift. So as opposed to in controls where once you move from one spot to the other, the eye stays steady, here there's a drift of the eye towards the target. And this has been attributed to the flocculus and the paraflocculus lesions. Which are also responsible for the nystagmus that drive the slow phase of the nystagmus. So it's the same underlying pathophysiology. The next thing I wanted to talk about was vergence. So cerebellum role in saccades is pretty well known, but cerebellum also plays a very important role in vergence. And so here's an example set up from our lab where we have the ability to quantify vergence, and we use these LEDs that are mounted on a bar. And I'm showing how we test convergence, where the subject is required to fixate on a distant LED, and then once they have maintained fixation, that LED turns off and the close-up one turns on, and so the eyes move in opposite direction and the same magnitude, and they converge towards the near target. So here's an eye position traces obtained during convergence from a healthy control. Again, x-axis in convergence from a control subject. X-axis is time, y-axis is eye position. The green and the red are the right and the left eye. Notice that the two eyes, they're moving in opposite directions. So this one, the green is going upwards and the red is going downwards. And then the vergence signal is the difference between the right and the left eye, and it's depicted as the dark blue here. And the latency is indicated by the red arrow here. And so we, in our positive, is the right eye is going to the left and the left eye is going to the right, and that elicits the positive convergence signal here. Now here's an example where we tested divergence. So the near LED comes on first, and then the distant LED comes on, and that evokes divergence where the eyes move out and in the opposite direction. And so here's an eye position traces obtained in a control subject during divergence. Again, the color scheme is the same, but notice this time around the divergence is indicated by this negative excursion here. So vergence and strabismus, they're very tightly linked. And in patients with cerebellar diseases, when they have convergence insufficiency or divergence insufficiency, they are known to produce strabismus. So the convergence and divergence pathways, they are separately arranged in the cerebellum. The caudal vestigial nucleus carries the convergence neurons, whereas the posterior interpositus nucleus carries the divergence neurons. And inactivation of these areas in non-human primates, so inactivation of the caudal vestigial nucleus, is known to produce an increase in the exotropia, whereas inactivation of the posterior interpositus nucleus is known to produce an increase in esotropia. So here's a schematic showing how how cerebellar diseases and when patients have vergence abnormalities can result in strabismus. So here's the neural circuitry that drives that. So the oculomotor vermis projects to the vestigial nucleus and the interpositus nucleus, and these in turn project to the midbrain supraoculomotor areas. These areas are known to encode the static eye alignment, and that has been shown in non-human primates. And then the SOA in turn projects to the oculomotor nucleus. So when you have lesions in the cerebellum, that can alter the static alignment, and it results in strabismus. Now, patients with cerebellum, they can present with diplopia, but as we all know that cerebellar patients also frequently have nystagmus. They tend to have gaze-evoked nystagmus and downbeat nystagmus. So sometimes the main problem is oscillopsia, and patients may not really realize or perceive the diplopia as much. And then as clinicians, when we're testing them, again, when you're doing cover-on-cover tests to look for the presence of strabismus, tropia, and phoria, you may actually, the refixation movement during the cover test may be obscured by the underlying nystagmus. A few types of strabismus have been commonly described in patients with cerebellar diseases. One is they have esotropia, that is worse at distance, and that's thought to be from divergence insufficiency. They can have skew deviation where one eye is higher than the other, or they can have alternating skew deviation where the abducting eye is higher than the adducting eye, and it reverses as we have them look in right versus left gaze. And then lastly, you can have pattern strabismus where the amount of horizontal deviation changes depending when you're looking straight ahead in up gaze or in down gaze. So this would be a V pattern, and in A pattern, you would have less of or more of a convergent strabismus in up gaze versus in down gaze. So next I wanted to talk about some common condition cerebellar diseases that have been that in which strabismus has been described. And we have published some of the papers, and I'll share some eye movement recordings that were obtained in my lab and that depict the eye movement abnormalities that you expect to see in cerebellar diseases, but also shows the strabismus. So first I'd like to talk about spinocerebellar ataxia. It's a progressive degeneration of the cerebellum and its afferent and efferent connections. It's autosomal dominant, and there are about 35 different subtypes. Machado-Joseph disease, also called spinocerebellar ataxia type 3, is the most common. It is located on chromosome 14, and there is trinucleotide CAG repeat within the coding regions. Their peculiar neurologic phenotype include dystonias and ataxias, and the most common oculomotor symptom is diplopia. Double vision is seen in up to 80% of these patients. And in SCA3, there's involvement of cerebellar vermis, the superior cerebellar peduncle, and the brainstem. Of note, the atrophy is actually mild compared to that of other SCAs. Here's SCA3 versus this is a healthy control. And you can see there is atrophy of cerebellum, but also there is atrophy of the brainstem areas. Now, strabismus, as I said, is pretty common. So we looked at the different kinds of strabismus in about 12 SCA3 patients. We found that 7 of them had ophthalmoplegia, where they had difficulty moving their eyes. All of them tend to have bilateral abduction deficit, and 3 of them later developed an upward deficit. And the ophthalmoplegia is attributed to the involvement of the brainstem. 9 out of the 10 patients had strabismus. Exotropia is what you would expect when they can't move their eyes, but in our cohort, only 2 of the 9 patients had esotropia. Exotropia was most common. 5 of the patients had exotropia, and then 3 of the patients had a V pattern strabismus. 2 of them also had skew deviation. So, in the next few slides, I wanted to actually show some of the eye movement recording videos demonstrating the strabismus angle. So here's a video of a patient who had abduction deficit and slowing of the saccades. There we go. So this is when the patient is looking to the right. Notice that the saccades are slow and he can't completely abduct the right eye. And this is when he's looking to the left. Again, the saccades are slow and he has the abduction deficit. CA3, they can also have slowing of the saccades in vertical direction. And here's an example of a slow saccade in the upward direction. The blue and the cyan are the vertical eye positions of the right and the left eye, and positive excursion is upward movement. Notice that there is a slowing of the upward saccade with an overshoot and a post-saccadic drift afterward. Also, there is a cross-couple response in the orthogonal direction, and I'll talk a little bit more about that in just a few minutes. Next here's a video of a patient who had exotropia. So although they have abduction deficits, it can be symmetric, and that's why they can actually they may not have esotropia. Instead, in patient, despite having an abduction deficit, he actually has an exotropia, and this could be due to convergence abnormalities. So besides having strabismus in primary position, these patients can have pattern strabismus where the horizontal strabismus varies depending on when they're looking in primary position or in up gaze and down gaze. And in this particular example, the patient had esotropia when looking in primary position, and then they had exotropia when looking in up gaze. Here's a cover test and a video showing the pattern strabismus in one such patient who had SCA3. So notice that she has a esotropia in primary position. Now when we have her look up, her eyes splay apart, which is the V pattern strabismus. So when we measure the eye movements of patients with pattern strabismus, what you'd expect to see is there is an orthogonal component. There's a movement of the eye in the orthogonal direction. So when they look up, their eyes, rather than just being up like that, they kind of also move. So they kind of move horizontally outward. So that is called the cross-couple response. So here's an example of one such saccade where the subject looks down. So the stimuli, this is the target. The target just moves down. So in normal controls, you'd expect them to just make a small downward movement, to match the target. But here, besides the vertical movement, there is actually a movement in the horizontal direction, in the orthogonal direction, and that is the cross-coupled response. So that can explain that can account for the pattern strabismus that we see in these patients. Now I wanted to just switch gears and talk about posterior fossa tumors and how these may present with strabismus. So posterior cranial fossa is the brain region that's most commonly involved in pediatric brain tumor. And tumors of cerebellum and brainstem, they can lead to oculomotor dysfunction that can result in nystagmus and strabismus. Now, posterior fossa tumor, obviously, they can disrupt the oculoefferent system, and there can be consequences such as abducens nerve palsy from nerve injury or downward displacement of the brainstem. However, A pattern strabismus has been associated with posterior fossa tumors. Similarly, pattern strabismus has also been reported in Chiari type 2 malformations, which affects the cervicomedullary junction. So I wanted to show an eye movement recording obtained from a pediatric patient who had a pilocytic astrocytoma that was arising from the vermis. And this is a pretty big lesion involving the cerebellum and parts of brainstem. And there was a fourth ventricular compression, and she had to have emergent surgery and was treated. But here are her eye movements. So she has gaze-evoked nystagmus. So when she's looking straight ahead, there is no nystagmus, but it's most evident when she's looking to the left compared to when she's looking to the right. So she has the asymmetric gaze-evoked nystagmus from asymmetric compression. Now, as I mentioned, posterior fossa tumors can cause pattern strabismus, and the most common is A pattern, where the eyes are more esotropic when they're looking in up gaze than when they're looking in down gaze. But in this patient, she had something which we called arrow pattern strabismus, where the eyes are fairly well aligned when looking straight and in up gaze and in straight ahead position. But when they look down, the eyes get esotropic. So you can see over here, the red is the left eye, and the left eye goes to the left. So this is the arrow pattern strabismus. Excuse me, the left eye goes to the right, which is the arrow pattern strabismus. Now, besides tumors and degenerations, Chiari malformation can also result in strabismus. So Chiari 1 is where there's herniation of cerebellar tonsils below the foramen magnum, and Chiari 2 is herniation of cerebellar tonsil, cerebellar vermis, brainstem, and or fourth ventricle below the foramen magnum with a coexisting meningocelular hydrocephalus. So symptoms these patients can present, usually they present in second or third decade of life, and they have symptoms, ocular symptoms in up to 80%. They can have retroorbital pain, they can have blurred vision, photophobia, and diplopia. So, and these frequently can be asymptomatic, and they're discovered incidentally on MRIs. They can have occipital or neck pain, and they which gets worse with Valsalva. So a variety of oculomotor abnormalities are seen in Chiari 1 malformations. The first is nystagmus, which is the repetitive to and fro movements of the eyes, and they frequently have a null position where the nystagmus intensity is least. These patients, they can have oscillopsia, blurred vision, and to sometimes even abnormal head position to put their eyes in the null position to minimize the nystagmus and the associated symptoms. Strabismus can happen in these patients, but it is not as common as nystagmus. And again, to avoid diplopia, they may adopt an abnormal head position. So here's a paper that we published in a patient who had Chiari and cerebellar tonsillar herniation that's seen in the MRI here. The cerebellar tonsils are herniated to level C2, and they're more involved on the left side than the right side. And what we found in this patient is that there was phoria that was only evident when we on the eye under the cover. So here's to the right here when are the eye movement traces of the left and the right eye, the horizontal eye position traces when both eyes were viewing, and we notice that there is nystagmus, but the two eyes are fairly well aligned. Now, when we tested the patient under conditions of monocular viewing, so in this, when the right eye is viewing, the left eye goes temporally, and then when the left eye is viewing, the right eye goes temporally. So the patient had phoria. And so we also noticed that there was a change in the characteristics of the nystagmus in binocular versus in monocular viewing. So here are the eye position traces obtained when both eyes were viewing. So we have straight ahead, right to 15 degrees to the right and 15 degrees to the left, up gaze and down gaze. And notice that when they're looking straight ahead, we have nystagmus, which is most pronounced when they look to the left. However, when they look to the right, the nystagmus is essentially gone. It's pretty silent. So that's the null position. Now, when we test them under monocular viewing condition, what we find is, again, it's the same 5 gazes, but this is right eye viewing and left eye viewing. What we find is that the null position is shifted. Rather than it being to the left, now the null position is shifted in the middle. And what we speculate is that the change in the eye position, because of the coexisting strabismus, is actually causing the reorganization of the null position. So we call this the shifted null. The next thing I wanted to talk about is cross-couple responses that we saw in a patient who had pancerebellar atrophy, as seen here on the MRI scans. And so, again, cross-coupling is that normally a control subject here, when they make a pure horizontal movement, primarily the eyes move in the horizontal direction with not any significant movement in the orthogonal vertical direction. So the red trace here are the horizontal eye positions, and the blue trace here are the vertical eye positions. And here, this is the data from the control on the right side. On the left side, we have the data from a patient with pancerebellar atrophy. And what we notice that when the control subject looks to the right and left, there is primarily just the horizontal motion with not much going on in the vertical. Similarly, when they're looking up and down, there is primarily a change in the vertical eye positions with not much change in the horizontal eye position. In patient with pancerebellar atrophy, notice that there is a pretty prominent cross-couple response in the orthogonal direction. So when the patient is looking to the right, in addition to the horizontal eye position change, there is an actual change with the saccade happening also in the vertical direction. And here to the right is a box plot showing the cross-coupling index, where we calculated the ratio between the orthogonal component to the saccade that should be in the expected direction based on the target movement. And notice that the cross-coupled ratios in patients for both vertical and horizontal saccades were greater compared to that of controls. Lastly, I wanted to talk about oculopalatal tremor. Again, these patients can have coexisting strabismus, so I wanted to share a video of a 42-year-old male who had a history of brainstem stroke secondary to aneurysm. And this video here shows that he had pendular nystagmus. It was primarily vertical, and he had a small torsional component, as well as a horizontal component. And these are the eye position traces. The frequency was about 2.5 hertz. This patient also had internuclear ophthalmoplegia, and the video will demonstrate that in just a minute, but where he had a left INO where he was not able to adduct the left eye, and because of that he had an exotropia, left exotropia in primary position. So again, this is just showing the vertical nystagmus, the superimposed torsional component. Notice the small XT that he has in the left eye, which is exotropic, and here this is where he cannot adduct his left eye. And then when we have him open his mouth, we can actually see the palatal tremor. You can actually see the tremor there. So oculopalatal tremor, these patients present with acquired pendular nystagmus. They have large vertical and torsional with a small horizontal component. The frequency is 1 to 3 hertz. They're dysconjugate. They often are associated with internuclear ophthalmoplegia or oculomotor palsies, and this can increase with eyelid closure. Palatal tremor, it usually does not develop until several weeks after the insult. So if you have acquired pendular nystagmus, and of course, we'll image and it will show. Usually, these can be associated with, these are seen in younger people, and aneurysm is one of the most common pathologies that lead to brainstem strokes. And it's the dentato-rubro-olivary pathway is affected, and nystagmus occurs because of impaired inferior olive output to the cerebellar flocculus. So how should we approach strabismus in these patients? So as we saw, that patients with cerebellar diseases and from a variety of reasons, including degeneration, from stroke, from Chiari malformations, tumors, they are at risk of developing strabismus. And so first of all, we would want to address the underlying neurologic problem whenever it's possible. If they have tumors, that needs to be addressed, or for Chiari malformation, sometimes they require decompression. For spinocerebellar ataxias, there are some medications that are being used in them, but there's no real data to suggest that it actually changes the strabismus. But you address the underlying neurologic problem. Now, if you have small angle strabismus, you may want to just give them prisms, or, if you are going to consider surgery, you would want to make sure that the measurements are stable. So while you're waiting to establish that, you can give them like a Fresnel prism, a stick-on prism over their glasses that can help with the double vision. You would want to address the strabismus that they notice primarily when they're looking in primary position, when they're looking straight, and in reading. these patients can have concomitant strabismus, so it may not be a perfect solution, the prism, nor the strabismus surgery sometimes. Our goal is to see if we can reduce or alleviate the diplopia in primary position. And then once measurements have been stable, at least for 6 months, you could consider strabismus surgery. But it is important to do a good consent and make sure that the patient understands that there is a risk of under and overcorrection, and in degenerative conditions, it's a progressive disease, so that the strabismus surgery may not actually be the best option for them in the long run, as the diplopia could change with time. So with that, I am going to stop, and I again would I'd like to thank all the organizers for putting together this session, and if there are any questions, I'm happy to answer them via email. My email is ghasia@ccf.org, and I hope to meet you all in person someday. Thank you again, and take care.